A couple of check-on learnings, just to kind of reinforce some of the concepts that we discussed yesterday. So our first one is a 35-year-old woman is found to have a fixed splitting of the second heart sound. Which cardiac abnormality is likely present in this case? What are your thoughts? We said fixed splitting of the S2 is a pathognomonic when we talk about congenital heart disease for a atrial septal defect. Do you remember that? So fixed splitting of the S2, think of atrial septal defect. And the reason you're having that fixed splitting of the S2 is all that extra volume that should be on the left side getting out of the left side of the heart and into the aorta is being sent across that atrial septal defect over to the right side, and now you have all this extra volume, this extra pressure that the right side is having to deal with, and it keeps that pulmonic valve open longer than what it normally should be. So that's why you'll get that fixed splitting of the S2. Okay, our next one is you have an 18-year-old student presents for evaluation of palpitations. Cardiac exam reveals a continuous machine-like murmur that is loudest inferior to the left clavicle. This finding is suggestive of which congenital cardiac abnormality? What are your thoughts? Remember patent ductus arteriosus? So you're having kind of this constant flow going across that patent ductus arteriosus. So that's why you have this continuous, meaning both diastole and systole. So you have that continuous flow going through that. And it's like this machine-like kind of auditory finding to it. Our next one is an asymptomatic 19-year-old college student is found to have a harsh holosystolic murmur at the the lower left sternal border, which does not increase in intensity with inspiration. Which congenital cardiac abnormality is likely present in this patient? Here in Charlie, ventricular septal defect. The most common congenital heart disease you're going to encounter. And the reason for that holosystolic murmur is that high pressure left ventricle is going to send all that blood volume over to the right ventricle. So you're going to have this kind of holosystolic flow of blood across from the left to the right. Now, you may be wondering, well, why did we mention anything about inspiration? This will be kind of more advanced when we talk about valvular heart disease, but that is typically indicative of a tricuspid regurgitation if it were to change with inspiration. But that's kind of more a block 3 question. But there is a point to having that extra little detail. We just haven't studied it yet. And then this next one is which congenital heart lesion is associated with Turner syndrome, which is that 45XO, where you're missing one of the sex-linked chromosomes. Coarctation, yep, see? So remember, we talked about two genetic conditions that are associated with congenital heart disease. The Turner syndrome was associated with the coarctation, but then we talked about DeGeorge syndrome, which was the microdeletion of chromosome 22, associated with tetralogy of Fallot. So two cardiac lesions associated with genetic anomalies. And then our last one was children with which congenital cardiac lesion learn to alleviate their symptoms by squatting? So B, we just looked at the video of that, right? So tetralogy of Fallot. The squatting, what it does is it increases afterload, and by increasing that afterload and increasing that resistance to the left ventricle outflow, it's encouraging more of that blood to go past that narrowing of the pulmonic outflow, or the right ventricle outflow, into the pulmonic valve and pulmonary artery, so you're getting more blood oxygenated. because path of least resistance otherwise without that squatting is for it to actually go out through the aorta and not through the pulmonic valve that is the pulmonary artery. So that's why squatting works. It increases afterload to increase the flow to the lungs. Okay. Questions about congenital heart diseases? Well, let's finish our last lecture of new material by talking about pericardial diseases or inflammatory or traumatic diseases of the heart. Tomorrow we will meet, it will be a review. I'm going to post the review slides after we're done with our lecture today. And basically these review slides are the high yield slides, I think, for the 6 lectures that we've done. So if you know everything on these slides, you'll probably get like a 98% on the test, okay? But what I've done is I've taken 600 slides, bring it down to like 200. So it'll focus your study. But if you do have questions on the review slides, what I am taking out is a lot of the context to why that topic is important. So if you're looking, you're studying, you're like, I don't quite understand what this is talking about, look at the actual lecture and look at those context slides to kind of help clarify maybe some of the confusion that you have, okay? If after that you still have questions, feel free to email me on Canvas or whatever. I'll answer those questions. Okay, so let's talk about pericardial diseases. So we talked about the anatomy of the pericardium, where it's basically like this 2-layer stack. And you have kind of the outer layer, which is like a fibrous layer called the parietal pericardium. And its role is basically to kind of attach to all these other structures around the heart to kind of limit the motion and stabilize the heart in its place. Then we talked about the inner layer being this visceral layer, and it adheres to the heart, and kind of also is synonymous with the epicardium of the heart, so the outermost layer of the heart. But the way this structure is folded, it creates this kind of this space in here that tends to have a little bit of fluid. Only about 15 to 50 milliliters of fluid is present in this space. And that's important, that fluid is important because it creates that frictionless environment for the heart to function and to operate in. It doesn't become a problem, that fluid doesn't become a problem until we start getting in excess of 200 milliliters. Then we start to see the function of the heart actually being impacted by there being too much fluid. And we'll talk about kind of that with the pericardial effusions and the cardiac tamponade portion of this lecture. But you can see there still is quite a bit of wiggle room of fluid allowed in that space before we start to see the function of that heart being impacted by it. We talked about in the first lecture what is the purpose of the pericardium. So one is just to kind of maintain its position so it doesn't move around. We talked about how it prevents that extreme dilation of the heart when you have all that blood flow coming back, particularly like when you're exercising and stuff, and you have that increased preload or that increased venous return coming to the heart. So it prevents that extreme dilation. And then we also talked about how it serves as a barrier to protect the heart from viruses, bacteria, other infectious agents that may gain access through like the GI tract or the lungs from getting into the heart and causing problems to develop. But that being said, the pericardium itself is not immune to infectious diseases that might cause problems and stuff. And that's where pericarditis comes in. So this inflammation of the pericardium, that layer, that tissue layer, and the impacts that that might have when you do have this infectious process develop. So based on just the definition of pericarditis, it's basically an inflammation, so itis being inflammation, right, of the pericardium. So pretty kind of obvious what we're trying to convey, provided you know how Latin works with naming of things, right? But this condition, this inflammation can develop because of a specific agent, so like a virus or a bacteria or something like that. But it could also be a byproduct of another systemic illness that triggers that inflammatory process to affect this structure. The incidence of pericarditis, we aren't exactly sure because the vast majority of folks don't ever present to a medical professional in order to get diagnosed with this, right? They may have a little bit of chest discomfort or whatever, not enough that they would want to go see a provider, medical provider. It also tends to affect kind of younger people, and younger people, we tend to not think that chest pain is associated with heart attacks, right? It'd be different if this was like affecting 65, 70-year-olds who have heart attacks all the time, right? If they have chest pain, they're going immediately to the ER. Well, it tends to affect younger people, so they don't ever present to the ER with this. That being said, if you do go to the ER for this, it's actually one of the more common conditions that the ER will diagnose with chest pain. And it's usually diagnosed in the ER because you're not going to go to your primary care provider with chest pain, right? In our mind, we're thinking chest pain equals heart attack. I'm not going to my primary care provider where they're not going to be able to do anything for me. I'm going straight to the ER for this, right? So this is a common diagnosis of chest pain in the emergency room. When we start looking at the causes, we have those infectious causes and we have those non-infectious causes. But when you look at viral or idiopathic, where we just don't know what the cause exactly was, this is the most common cause. And you can look at the viruses that you have here. How common are these viruses that we see in the community? You've got Coxsackie virus. If you have a kid in daycare, you probably have had it a couple of times. Epstein-Barr virus, so mono, also a very common thing, especially in college-aged students, right? So it doesn't have to be a more serious type of virus like HIV causing this. These can be caused by very common viruses that we have in the community. There are other bacterial things like tuberculosis and other things that can cause this as well. And you would imagine if you're probably having it caused by one of those more serious conditions, probably the presentation is going to be more serious as well. And those are probably people who are going to be going to the emergency room. But when you look at the non-infectious things, basically think of these are conditions that trigger an inflammatory process, right? So you had a heart attack. Well, if you have that heart attack, you may have that inflammation develop within 2 weeks or acutely, where the pericardium gets inflamed because you're having an inflammatory process that's trying to heal the damage that was done with that heart attack. So it triggers an immune inflammatory response, and it just happens to take down the pericardium as well. We did a cardiac surgery. Well, we're manipulating tissues and stuff like that. That could trigger that inflammatory process. Connective tissue diseases, radiation. So there's lots and lots of things that can do it, to include medications that we give them. All meds have some kind of side effect profile to them, right? That's what pharmacology is studying all about, right? And you got to learn how to identify who's at risk maybe for some of these side effects, or just having a high index of suspicion if they are on a medication like this that happens to trigger this side effect. So this is just a list of kind of the medications that you might think of, to include minoxidil. So our male patients who have a little hair challenge on the top of their head, who are taking minoxidil to help with hair loss, it could trigger a pericarditis to them. So how and why does this inflammatory process develop to impact the pericardium? Well, whatever that causative agent is, whether it be that virus, that bacteria, or those non-infectious causes, it causes a vasodilation, which increases the permeability of like the capillaries in the blood, so that you have this fluid that kind of triggers this response. Okay, that permeability goes up. You get that fluid accumulate. That triggers that inflammatory process, which an inflammatory process is a coordinated response, typically in a setting where we want it to respond like that. But however, it can kind of have some secondary losses associated with it. So in this case, what ends up happening is that inflammatory response starts to deposit fibrin, which then triggers that inflammation and then leads to the development of this condition. So the 3 stages for the development of pericarditis is that vasodilation and the transudation of that fluid, the increased vascular permeability, leukocytes come in, and then it starts having secondary casualties to it and leads to the development of this condition. Now, what can you see if you were to look at the heart at kind of all the different stages or different causes of it? The most basic kind of inflammatory response, where you're just getting that permeability of that fluid, is going to be this very thin exudate. Okay, so it's kind of clearish looking. You can read a newspaper through it. It may not cause really any symptoms, or just very mild symptoms even at this stage. So we typically won't see this stage because people usually at this stage are not coming to get evaluated necessarily, or their condition's not bad enough that we're going to want to open up the pericardium to look at it, right? Well, as that inflammatory response continues, becomes more organized, you start getting that fibrin deposition. You start to get this bread and butter, or the serofibrinous appearance to that exudate. And you can see this is a much more complex kind of exudate there. And you can imagine, if you're having this, folks are probably going to be coming to the hospital to get evaluated because they're going to be so symptomatic from this. So if we did procedures to look at the fluid or look at this exudate, this is the one that's most commonly observed. Doesn't mean it's the most common, it just means it's the most commonly observed. If you have a bacterial cause, so you have somebody who's immunocompromised, which could be the typical things we think of immunocompromised states like HIV, but it could also be poorly controlled diabetes. That is an immunocompromised state as well. Those folks are going to be more at risk of more complicated, complex kind of conditions, and you can get this suppurative kind of appearance. And you kind of think of this is an abscess that's forming from around the heart. Abscesses are so difficult to treat in the first place. Imagine that forming around the heart. This leads to a very high mortality rate if they get to this point in the condition. So not only because you have this abscess, but also too, they tend to be immunocompromised, so they're not going to really fight this infection very well, very easily. And then the last kind of appearance to that exudate could be bloody, which typically we think of tuberculosis or a cancer as the cause for this. And of course, it looks hemorrhagic around there. So you may even think that this might be like a traumatic kind of thing that led to this, but really it's just tuberculosis or cancer that led to the bleeding into that area. So what are you going to see when they come and present to you with pericarditis? Well, they're going to be chest pain. 95% of patients are going to come in with some kind of chest pain. It's going to mimic a heart attack kind of chest pain. But you, with your history-taking skills, could easily rule out heart attack simply by asking palliative and provocative factors. Pericarditis tends to be what we call a positional chest pain, which is it gets better with sitting up or leaning forward, and it gets worse when you lay back or with coughing or taking a deep breath in tends to make that pain worse. If you're having chest pain related to a heart attack, those positional changes are not going to change that pain. Typically, we think of rest and exertion as the things that change heart attack kind of chest pain, okay? So make sure you're doing a good history and asking about these positional changes when you're evaluating a patient for chest pain, because it can help you differentiate more serious conditions versus a less serious cause. Now, what are you going to see additionally on your physical exam? Well, because this tends to be more commonly like a virus that's causing it, they may have a fever. They don't have to have a fever, but they may have a fever. If they do have, like, especially high fevers, then maybe be thinking of like bacterial causes for this. But fevers are common to this. And then the biggest thing that we see on auscultation is going to be that friction rub, right? I'm going to get out of this and let you hear what that friction rub could sound like. So you hear the typical love, love, and dub of the heart sounds. This one has two, right? There's also kind of like a Rice Krispies kind of popping kind of sensation. So that's going to be your. There is speaker static there too, which also confounds it. When we do our lab, I'll let you hear that using the infrared stethoscopes, which will make it a lot easier to actually appreciate that. So, yeah, an auscultation, you can hear a friction rub commonly in those patients. Now, if we said that the vast majority of cases are associated with just the idiopathic or viral kind of causes, what things should we be looking for to see if we should be suspicious of, a more complicated, more severe kind of conditions? And the red flags for this is if they have high fevers, especially, and a leukocytosis, you should be thinking of a bacterial cause. If you have a large pericardial effusion, then that might be concerning. If we have tamponade, which is the difference between tamponade and pericardial effusion, is just that effusion, that fluid, is affecting the actual function of the heart. Okay, so that's really what the delineation between an effusion and tamponade is. If they're immunocompromised, they're more likely, more susceptible for severe causes of this. If they're on anticoagulation, that's concerning because for a couple of reasons. One, they may be more prone to bleeding in that area if they're on anticoagulation. But when we talk about the treatments may interact with that anticoagulation and make them more prone to bleeding. So we have to be careful with that. And then if they have an elevated troponin, which is indicative of like myocardium stress or death, then we have to be concerned that that inflammation has actually gotten into the cardiac muscle itself. To diagnose this, you have to have two of these things, okay? Which typical chest pain, we said 95% of our patients are going to have the chest pain. So 95% of your patients with this are going to have just this one criteria. So I just need one more of these to actually have that diagnosis made. But don't limit yourself to pericarditis. You have to keep that differential diagnosis there. So things that you should be also thinking about are acute coronary syndrome, which is going to be your heart attacks, your aortic dissection, and even lung causes of chest pain. What else could we see on our ancillary studies? So EKG, the findings that you might find on your EKG could be, we usually say the diffuse ST elevation, so it's not limited to a geographic area. So this could be, you have ST elevations in the LAD regions, but you also have ST elevations in the right coronary regions as well. That doesn't make sense that you're having disruption of blood flow to both of those areas at the same time. So be suspicious for pericarditis. You get PR segment depression, which you can kind of get a good example here in lead 1, where that PR segment goes down from its baseline. You can get a concave upsloping ST segment, so you can kind of see its concave appearance. And then Spodek sign, which is the downsloping T to P segment, which is a great example of that is in this one where you see it V4 here, but you're going to also see that here in this V4 where it slopes downward from that T segment to the start of your P wave. But 90% of patients with pericarditis are going to have an abnormal EKG. So we said you only need 2 criteria of those 4 to be positive. One was the typical chest pain, which 95% of your patients are going to have chest pain. And then we said one of the other options is your EKG pattern. And we said 90% of patients are going to have an abnormal EKG. So you can see just with those 2 things, and that doesn't include hearing the pericardial friction rub, and it doesn't include the new or worsening pericardial effusion, which is probably the least common for acute pericarditis. But you can see how easy it is to get to those 2 things to be able to diagnose somebody with pericarditis.
So would a patient on their EKG, would they have all, some, or none of these? Like, is it possible that
they won't necessarily have all of these, but they'll have several of these findings. Yeah, I don't want to say all, but yeah, they'll have like the diffuse ST segment elevations with the Spodek sign or with the concave upsloping. Those kind of things.
Right.
You definitely have to think about it. Yep, and that's where your history is going to come in. You're still going to get troponins because even if this is not a heart attack, you're thinking that this is pericarditis. You're going to want to get those troponins to make sure you don't have a myopericarditis where you have inflammation of the pericardium and inflammation of the myocardium. Because that inflammation of the myocardium puts them at a higher risk of other problems downstream. So, especially when we talk about return to play and those kinds of things, or return to activities. It still is positional because you still have that, taking the kind of that pressure off of the pericardium, that inflamed pericardium, so you still have that. But you're going to be getting your cardiologists on board pretty easily, and this is definitely something you're going to be wanting to send to the ER. If you're seeing them in the primary care clinic, you're going to be wanting to get them over to the ER. So for our other ancillary studies, what could we see? Well, if you have a pericardial effusion, so you have a complication that is developing because of the pericarditis, you could see a widened mediastinum, and you'll see a sign of this water bottle sign, which is just basically that effusion that's present. Now you may be looking at it and be like, well, this doesn't look like my Stanley Cup, it doesn't look like my Yeti or whatever water bottle you have. It's based on that like lambskin bottle that you see there. So when they first came out with x-rays and described this finding, this was the water bottles of the time. So, but chest CT is also a great way, and you can see that inflammation, or sorry, that effusion in the pericardium. But echo is probably the best imaging study that you should get for these patients, because not only can you see that effusion, not only can you measure how much effusion is present, but I can also then see what are the secondary consequences of that effusion. Am I impacting the function of the heart? And now I have like a tamponade kind of picture. based on that effusion that is there. Let's say they get that echo when they initially present, and it doesn't look like there's any issues. You are going to want to repeat this echo, which this is when you get your cardiology colleagues on board to help you manage these patients. But you're going to want to get another echo about 1 to 2 weeks later, just to make sure they haven't developed this complication while they've been undergoing treatment and stuff. So let's make sure they haven't developed this complication, because it may change how we treat and manage these patients. When you go to evaluate your patients, don't shotgun your workup. Try to be more targeted to the risk factors for these patients. If you have somebody who's not at risk for lupus, there's probably no point in testing for lupus, right? If you have somebody who's not at risk for HIV, then don't test for HIV. If you're not at risk for tuberculosis, don't test for tuberculosis, right? So it could be, for a low-risk individual, the only thing you really are doing is your CBC to make sure they don't have like a leukocytosis. What's their inflammatory markers, just to confirm that this is an inflammatory process. Let's check their cardiac enzymes and just make sure that this is not a myopericarditis. And also make sure it's not a heart attack. But those would be kind of at most, the basic labs to do on your patient with acute pericarditis. So how are you going to treat this? Well, fortunately, we did say that the vast majority of patients who have acute pericarditis don't ever come to a medical provider and get evaluated in the first place. So fortunately, most of the time, this is just completely self-limited. The inflammatory process occurs, and then it goes away. And then the patient is fine. But if they do present to a medical provider, do we want them to just exist with chest pain for a week or 2 weeks? Is there something that we can do to help them feel better, right? I don't want them coming in every 12 hours to the ER because they're having chest pain and thinking that now they're having a heart attack, right? So what can we do to help manage their pain? Something as simple as an NSAID and an anti-inflammatory kind of medication can do this. So typically we think of colchicine and an NSAID of some sort, which we have a number of different options in that category. And that will help manage their pain so they feel comfortable. They're able to do the things they need to live and to function, and they're not just bedbound because of that chest pain. Or they can actually sleep, because of course it tends to get worse if you lay flat, right? But the additional benefit for doing this regimen is it prevents permanent complications developing down the road. And we're going to talk about one of those complications towards the end of this pericardial section. But the treatment, if they do present, is a combination of colchicine and an NSAID. The one caveat, though, with which NSAID you choose is if this is in the setting of they just had a heart attack, you don't use ibuprofen, you don't use indomethacin to treat it. You're going to be restricted to using aspirin. And the reason for this is if they just had that heart attack, they had some cells, some myocardium die, now you're going to have this inflammatory process to try to clear out those dead myocardial cells and replace it with a scar tissue, right? If I give them something like a non-steroidal anti-inflammatory like Motrin or indomethacin or even naproxen or naproxen, those can interfere with the formation of that scar, and now I have the immune system knocking out those dead cells without that scar tissue being laid down, and now I'm at risk of having that ventricle wall rupture. And now I'm bleeding into the chest with high pressure blood, right? So if you have acute pericarditis, in the setting of they just had a heart attack, do not give them any NSAID other than aspirin. So in those patients, you just have colchicine and aspirin. Okay, so that's the one caveat on which medication regimen you can do for these patients. So we're going to follow up with these patients in that 1 to 2 week interval after they've started treatment, because we're going to make sure that they haven't developed a complication, i.e. like the pericardial effusion, that excessive fluid accumulation in the pericardium. But other things that we're going to want to look out for is recurrent or chronic pericarditis, which is the most common complication that develops, right? If they've had pericarditis once, they have an increased chance of having it happen again. Pericardial constriction, so this is what we're trying to avoid by doing that colchicine and NSAID combo for at least that 2 week mark, or the 3 weeks. We'll talk about some of the consequences that develop with that, but just think of this is a scar tissue that forms in the pericarditis. And then of course the effusion, so that excessive fluid accumulates in that space. So we talked about how they're going to have that repeat echocardiogram, but the other thing you got to remember is they should avoid strenuous activity for at least 4 weeks, because especially if they have that myopericarditis, if they return to play or they return to a physical activity, a strenuous activity, then it could actually lead to further damage and destruction of cardiac muscle, leading to even more severe disease. So make sure they avoid strenuous activity for at least 4 weeks. Questions about acute pericarditis? Okay. So let's move on, and now let's start talking about pericardial effusion before we go on break. So we said normal fluid is 15 to 50 milliliters of fluid in that pericardial space. Once we get above 50, technically we now meet the definition of effusion. But it's not until they get above like 200 to 250 that all of a sudden that starts to limit the function of the heart. So now that gap of 51 to like 199 milliliters is kind of this area where you just have this excessive amount of fluid in the pericardial space. And what can cause this, a lot of these look similar to the things that cause acute pericarditis, right? We said viral, we said bacterial, we said radiation. Cancers go up on the list for causing this, because the cancer, wherever it is, can impact that permeability of the vascular system, which can lead to that fluid accumulation, regardless of other things like viruses triggering that to happen. But one thing that's kind of interesting is, you haven't talked about this in endo yet, but hypothyroidism, one of the symptoms of hypothyroidism is myxedema swelling, myxedema. Well, that swelling is because of an increased vascular permeability, and so that condition, that hypothyroidism, could cause that permeability to occur really anywhere, and you start to lose fluid from the vascular space into other spaces, and the pericardium is a great place for that to happen. So hypothyroidism could be a cause for a pericardial effusion. How are they going to present? It's going to be kind of dependent on, one, how much is there, and two, how quickly did it accumulate. If this is kind of a slow process, then your body can compensate for that, right? But if this is in a matter of 30 minutes you accumulate this excessive fluid, the body cannot accommodate for that or compensate for that, and then it will cause symptoms to develop. So if they happen to have symptoms from this, what might they have? Well, it could be a mass effect kind of thing where other structures around the heart are getting impacted or being pressed on and limiting the function of those things, because the pericardium is a limited space, right? So I can't just continue to grow without any limits. I'm going to have to grow at the expense of surrounding structures. So it could be like it starts to compress the lungs and now they start having shortness of breath because of that fluid in the pericardial space. It could be that it compresses the esophagus. The esophagus runs behind the heart, right? So now they're having problems with swallowing. It could hit the recurrent laryngeal nerve as it comes down and loops up and goes right back up. And that can cause hoarseness. It could impact the phrenic nerve, and now they've got hiccups. So you can see all these kind of structures around the heart could get compressed and start to not function properly and leave that. An interesting physical exam finding that you may have is this thing called Ewert's sign, where you'll percuss the back, and over the posterior left lung field, there'll be a dullness, and it's because you're tapping over that fluid space. What else might you find on your ancillary studies with this? You may have this, especially if you have a large effusion, you may have this electrical alternans on your EKG where the amplitudes of the QRSs change from beat to beat. So basically kind of think of this as like a baby in the amniotic fluid in utero, where that baby can move around any way it wants, right? In a large pericardial effusion, the heart can swing around in that fluid-filled space, and what can happen is one beat, the heart's closer to the EKG leads, and then that next beat, it's swung away from it, and now that amplitude changes. So you'll see this change in the amplitude from QRS to QRS. Your echo is going to be your best test of choice because, again, you can measure it, but you can also then see what are the additional impacts associated with this. So getting an echo is going to be important. If we need to stick a needle in there to drain that fluid off, so now you're in like the treatment part to this, that echo will help you with your needle placement. So you can kind of do the echo, confirm it's an infusion, and then place your needle at the same time. For workup, don't shotgun the approach. Try to see, based on history and physical, what are the possible etiologies of this, and test for those. Otherwise, this is a pretty expensive workup to do with very little yield to it. And then the treatment's going to be, one, treat the underlying cause. Is this a cancer? Is this a virus? Do those things. But then, if you have mild symptoms, so that they're like don't have any mild case where it's minimal symptoms or no symptoms, then you're just going to watch them closely just to make sure that that fluid doesn't continue to accumulate and get larger. If they have moderate to severe, then let's stick a needle in it, that's a pericardiocentesis, and drain that fluid. And then we got to watch to make sure that that fluid doesn't reaccumulate. If it does, then maybe we need to stick another needle in it. But if this keeps happening, then our last resort is we actually do a surgery where we cut a hole, we cut a window in the pericardium, so now you don't have a space for that fluid to accumulate. So that's our typical treatments for a pericardial effusion. Let's go ahead, let's take 10 minutes, we'll come back at 11, and then we'll finish up. Cardiac effusion, which is basically you have fluid in excess of normal, but it's not limiting the function of the heart. Okay. Now let's move on and let's start talking about tamponade, cardiac tamponade, where now that excessive fluid in the pericardial space has now reached a point where it's now interfering with the actual function of the heart. Okay? So if you look at the things that can cause this, the list is pretty similar to the etiologies that we've talked about before as far as the pericarditis and even the pericardial effusion, right? It's just now that fluid that has accumulated is now in excess of it. But let's also now throw on the traumatic causes. So the things that we typically think of is like that blunt chest trauma, motor vehicle accident, steering wheel to the chest kind of trauma, gunshot injuries to the chest, and then even a dissecting aortic aneurysm, which we're going to talk about that at the end of block 2. But you can see now you have those traumatic causes where this is causing that excessive and in some situations a sudden increase in fluid in the pericardial space, which then leads to the function of the heart being impacted by it. Now, when you look at it, the pathophysiology of what's happening in this condition is you have this extra fluid accumulating around the heart. It's going to put a constant pressure on the heart structures, and it's going to lead to a decrease in the venous return. So now I'm not having as much volume of blood coming back to the heart in the first place, which means that I also don't have a lot of blood to go from the atria and into the ventricles, right? But at the same time, that pressure on the ventricles is leading to basically not allowing that ventricle to expand to take whatever volume is in the atria into the ventricle. So now both the atria and the ventricles are impacted. I'm reducing my preload, so that end diastolic volume, right? So I'm reducing my preload, which now means that I'm going to be reducing my stroke volume, which means my cardiac output is going to be impacted by this. So by reducing that cardiac output, I now am not going to be able to maintain a adequate blood pressure to perfuse my vital organs. And now I have that hypotension. And that hypotension is actually an important thing because the clinical feature of cardiac tamponade is Beck's triad, which the first item on the triad, so 3, is hypotension. Okay, so that's the first criteria for it. Jugular venous distension. Because I'm not taking on that blood volume into the atrias, it's going to back up into the peripheral venous system. So I'm going to see that jugular venous distension. And then the third criteria for Beck's triad is that muffled heart sound. So basically, because I have all of that fluid surrounding my heart, I'm not going to be able to detect those heart sounds as easily, because now I have more space that has to go through, but I'm also limiting the actual function of the heart. So it's going to be difficult to actually hear the normal S1, S2. So Beck's triad is kind of the classic finding for cardiac tamponade. The other thing that you might see is if we were looking at our jugular venous pulsation waves. So we talked about this in lecture 2 of this block. You lose the Y descent. Now, if you don't recall, the Y descent comes right before the A wave, which is your atrial kick, right? So what's happening right before the atrial kick? It's that passive flow of blood from the atria and into the ventricle with that tricuspid valve open. So it's that passive diffusion. I'm going to lose that because I'm losing venous return, so I'm losing that volume of blood to even come to the atria to go into the ventricle. But then also I'm having that external pressure exerting on the ventricle, so now that ventricle doesn't want to take on a volume. So I'm losing that passive flow. So I may be reliant on that atrial kick to really get any kind of volume in the ventricle. Other things you're going to see on your ancillary studies. So when we said if you have a large effusion, which think of cardiac tamponade, if it's limiting the function of the heart, that's going to be a large effusion. So the EKG, you're going to see this electrical alternans, like we talked about. course, the echocardiogram, you're going to see that pericardial fluid. You're going to be able to measure the impacts on the actual function of the heart, because you're going to see that the preload, the end diastolic volume is pretty low, and you're going to see that end systolic volume is going to be pretty low. There's not going to be much of an ejection fraction actually there. So you'll be able to see that on the echo. Your workup, again, don't shotgun a workup. Target what it is. You're going to, because you are having a functional limitation to the heart, you're going to want to pull that fluid off. So this is kind of a treatment / diagnosis where you're going to do this pericardiocentesis. And you can actually analyze, if you're still questioning, well, they didn't have a traumatic event that caused a bleeding, a sudden bleeding into the pericardial space. So you're questioning, well, what exactly is this? Analyzing the fluid using Light's criteria can actually help you with your diagnosis. Please, 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 please do not memorize the Light's criteria as far as each of these values. This is going to be a lookup. What I expect you to know is, hey, I can use Light's criteria to help me diagnose it. And what Light's criteria is going to do is, if I look at the specific gravity of total protein, the fluid to serum protein ratio, the fluid to serum LDH ratio, and the fluid to serum glucose ratio, if I look at all of those things of that fluid that is present in that effusion, I can tell you, is it an exudate or is it a transudate? If it's an exudate, I know it's either cancer, infectious, or collagen vascular disease. If it's a transudate, then I know this is post-radiation, this is uremia, this is hypothyroidism, or trauma. So I can differentiate at least large groupings of what this could be. So now I know, like, okay, I know it's an exudate. Now let me test to see if there is a cancer. Let me test to see if there's a collagen vascular disease. Let's do a viral test to see if a virus caused this. So I can really limit and tailor my testing based on the etiologies that are present if this is an exudate or if this is a transudate. So Light's criteria can also be used for pulmonary effusions, which we're going to talk about in pulm. So Light's criteria can be used for pulmonary diseases as well. So how are you going to treat it? Well, first thing is, let's try to support their blood pressure. So let's get IV fluids infusing, try to bring their blood pressure up while we are setting them up to do that emergent drainage. So it could be just doing a pericardiocentesis, which is just sticking the needle in and pulling off that fluid to restore that function of the heart again, because you're taking off all that pressure, so you can encourage that venous return, to encourage the ventricle to open up and take on that volume to be able to actually support a reasonable cardiac output. But it may need something a lot more aggressive to treat it, especially if this is like a recurrent kind of thing, where I go in and I just remove a portion of the pericardium so that any fluid that does accumulate, like in a malignancy kind of scenario, will just kind of spill out into the chest and then get reabsorbed that way. So I may, depending on the cause and depending on if this is a recurrent kind of thing, I may need to do something a little more aggressive. I'm not going to expect you to know what this is, but if you're wondering what a VATS is, that's a videoscopic assisted thoracoscopic surgery. So instead of doing a huge incision, opening up the chest, I can actually do just cameras going in there and do the surgery. So, all right, so let's talk now about our last pericardial disease, and that's this constrictive pericarditis. Okay, we kind of alluded to this as a complication of acute pericarditis that happens, years down the road after the inflammatory process. But think of constrictive pericarditis as a scar tissue that develops in the pericardium itself. So after an inflammatory process of some sort, you now get scarring, and now you get this kind of rigid pericardial sac. And typically what you're going to see is this fibrosis, this thickening, adherence, and then calcification, just to kind of show that scarring that's there. And imagine, okay, the pericardium should be a frictionless, or create a frictionless environment for the heart. If I have this kind of disease, is it still frictionless? And the answer is, of course, no, right? I now actually am going to have a lot of resistance. I'm going to have a lot of friction there that's going to interfere with the work and the function of the heart. So the etiologies of this, so kind of think of this as a complication that develops because of an inflammatory process. So things that cause like acute pericarditis are going to be things that are going to cause this. And you can see the most common cause in a developed country is the same things that cause acute pericarditis. Okay? There are some other things out there, some not as common in developed countries compared to developing countries. But you can see the list is pretty similar to things that cause pericarditis. Now the pathophysiology of constrictive pericarditis is actually pretty similar to cardiac tamponade. Ultimately, it leads to an impaired diastolic filling of the ventricles, which then leads to reduced cardiac output, stroke volume, and kind of a backup of blood upstream, which then can lead to like those heart failure kind of symptoms. So the pathophysiology is very similar to cardiac tamponade. But remember, this is a diastole kind of thing. So systole, the ventricle is going to squeeze, and it's going to get whatever volume happens to make it into the ventricle during diastole. It's going to get that out. It's just, you just don't get much of a volume coming into the heart in the first place. And the things that you're going to see with the presentation of the symptoms associated with constrictive pericarditis is things leading to poor cardiac output. So think of, you're just not having much of a volume, not much of a blood volume circulating around. Can I support the other functions of the vital organs? Because I'm just not circulating an adequate volume. So I'm going to have things like shortness of breath. I'm just going to have no energy whatsoever. Hypotension. I'm going to try to compensate for that low cardiac output by increasing my heart rate. I'm going to have abdominal pain because all that fluid from like right-sided heart failure is going to kind of get accumulated in the abdominal cavity. I'm not going to be wanting to really eat anything because of all that extra fluid that's accumulating in the GI tract and around the GI tract in the abdominal cavity. So I may start to lose a lot of weight with that. So those are things that you might see develop with this. And this takes years to develop. So this is not somebody who has acute pericarditis and then a month later is coming down with this. This could be decades later that they come down with this. So that's why taking that past medical history is important, because it could be you have your explanation as to why they're experiencing these types of symptoms, because they had acute pericarditis 30, 40 years ago. On your physical, what might you see? So you're going to see the things of like right-sided heart failure, so all that fluid accumulating in the peripheral venous system. We talked about Kussmaul's sign, which is that increase in the jugular venous pulsation wave with inspiration. Normally, you should see a decrease in the jugular venous pulsation wave with inspiration, but in this condition, because the ventricle does not want to accommodate all that extra volume coming back, it's going to back up into the jugular vein. Chest X-ray, because of that scarring that's there, you're going to see the calcifications in the pericardium are kind of surrounding the heart silhouette. EKG, one of the most common things you're going to see, because you have that scar tissue that's going to interfere with the leads detecting that electrical conduction. You're going to get that low voltage wave. Echocardiogram, you're going to see the thickening of the pericardium, you're going to see the calcifications, you're going to also see that limiting of the actual movement of blood volume into the atria and out of the atria. But one of the things that's kind of interesting is when you look at the jugular venous pulsation waves, there's actually going to be a subtle difference. So we said that pathophysiologic effects of pericardial constrictive pericarditis is similar to cardiac tamponade, but when you do the jugular venous pulsation waves, there's going to be a difference between the two pathologies. So we said tamponade, you lose kind of that wide descent, right? But in constrictive pericarditis, you actually get a prominent wide descent. And you can kind of get an idea of this here, where it's like a sudden drop off, but then a quick and sudden rise. And the reason for this is with tamponade, you have a constant pressure exerting on the heart that's disrupting that venous return, right? And then it's also disrupting that flow from the atria and into the ventricle, because that ventricle is getting that constant pressure against it, so it doesn't want to expand to take on that volume. With constrictive pericarditis, you're going to have venous return to a point before it kind of reaches its max and hits that rigid scar. But then, so you do have like an increased volume compared to a cardiac tamponade coming back to the atria. But then the ventricle is going to have that normal elasticity to a point where all of a sudden it's going to like start to open up, it's going to start to dilate to take on that volume, and then all of a sudden it hits that rigid scar, and then it stops. And then that pressure rapidly increases because it's not going to take on any additional volume without increasing that pressure. So you have it where you get that passive flow of blood from the atria into the ventricle, and then all of a sudden it reaches that point, it reaches that scar, and then you see that rapidly increase and go back up. So that's why you see that difference in cardiac tamponade and constrictive pericarditis in the jugular venous pulsation waves. Does that make sense? So how are you going to treat this? Well, this is a chronic problem. This is a permanent condition, right? It's going to progress and get worse, especially as that scar tissue continues to get worse, where it's going to kind of get tighter and tighter band around the heart. So there's not a medication necessarily that we can give to treat this. So we're kind of stuck with surgical approaches as our only treatment for this. And unfortunately, it means removing the entire pericardium. So removing that entire scar tissue to release that band around the heart to restore that function to the heart. And you can imagine, think of all the vital structures that that pericardium is attaching to or is, interacts with. And, oh, by the way, it's scar tissue, so now it's adhering abnormally to all of these structures too, right? This carries a pretty high mortality rate. 20% of folks who need to get this done will die in the procedure. However, if you survive, 90% are going to have significant improvement in their symptoms. So now they're able to actually walk upstairs, they're able to interact with their grandkids, they're able to do things and exist, not just be bedbound, because now they have a return or a restoration of their cardiac output to function.
Is like anything attributing to that mortality, like comorbidities or like something in particular, infection?
Not necessarily. I think this is more like in the OR, you carry like a 20% mortality.
Okay.
And it's just really because guys have started GI, right? We have like adhesions that develop in the abdomen because you've had some other abdominal surgery. Those adhesions will attach to other structures, and it could cause like a bowel obstruction because of it. So if we have to then go back in and do another abdominal surgery, we run the risk of puncturing the bowel because we're trying to get those adhesions down because they've abnormally adhered and scarred to all these other structures. Same thing is happening with this condition. You're having that scarring abnormally adhering and interacting with structures that it shouldn't. So it just makes it a very complex surgery. All right, so let's finish now with our last inflammatory topic, and this is the myocardium is inflamed, myocarditis, okay? So we talked about how you could get the inflammation of the myocardium in pericarditis, but we're going to talk about this as a kind of like an exclusive kind of thing. This kind of garnered a lot of interest, which is probably why it made it to the 2025 PANCE blueprint, even though it's rare, because this is one of those complications that we saw with COVID-19. You heard about myocarditis. You also heard about myocarditis because of the COVID vaccine, right? So the condition, the disease caused myocarditis, or could cause myocarditis, but the vaccine could also cause it. So, why do we see that? It's a good question that I don't have the answer to, but this has garnered a lot of attention because this was one of the reasons a lot of folks were hesitant about getting the vaccine because they didn't want this condition to develop. So by definition, it's just an inflammation of the myocardium, not in the setting of a heart attack, okay? So it's just an isolated inflammation of the myocardium. And it can have a lot of different kind of presentations to it. It could be acute. It could be that it takes a while to kind of develop, or it could be that this is a chronic condition or a chronic thing that's leading to this. It's fortunate that it's not a very common condition. We don't see a lot of this in the general population. This does not include like COVID-19 data. This is pre-COVID. This is what we saw. But it does carry a mortality rate, although not high, but there is a mortality concern with this disease. When you look at the potential causes of this, a lot of this looks similar to the things that cause acute pericarditis, right? That's why we can see this go hand in hand with acute pericarditis, because the same things that cause acute pericarditis can also cause myocarditis. Excluding like parasitic kind of infections that you might get if somebody's traveling abroad, kind of things. But you can see that. The presentation of somebody with myocarditis is going to be a pretty broad thing. It could be completely asymptomatic. Yeah, maybe they have like a little subtle chest pain, but they rebound fine. They don't ever present to anybody in the medical field. But it could be that they actually present with death. So you have no idea what's going on until they come in with sudden cardiac death. So you can imagine this is a difficult disease to manage when the spectrum of presentation is just so wide to they never go and see medical personnel at all to they're dead. So this is a very complicated disease to manage. If they do happen to come to you, what might you see? Well, it's going to depend on the severity of that myocardial dysfunction because of that inflammation. It could be you don't see anything abnormal at all. They just have a little bit of chest pain. But if that myocardial dysfunction affects enough to now it's affecting the actual function of the heart, you may start to see signs of things like heart failure, which will include things like jugular venous distension, peripheral edema. You may get murmurs being present because of abnormal flow and abnormal function of the heart valves as well. On your diagnostics, what can you see? Well, EKG are going to be kind of like non-specific things. You may be thinking other things are there, so like pericarditis, you may see the typical diffuse ST elevations like you see in pericarditis. You may see a localized ST elevation. Let's just say you have, the left ventricle is affected by this. You may be thinking that they have a LAD distribution, perfusion defect leading to a heart attack. They may come in because of the inflammation of that muscle affects the conduction system. They may come in with weird kind of arrhythmias and those types of things. So those are the things you could see on your EKG. Chest x-ray may be normal if the function of the heart is normal, okay? If the function of the heart is abnormal, then you may see an abnormal chest x-ray. So if you're seeing a fluid accumulating in the lungs because the left ventricle is not functioning properly, then you may start to see the pulmonary congestion developing from that heart failure. Okay? But then in large part, that's going to be normal. When we talk about our labs, you may, because this is an inflammatory process, you're going to have those inflammatory markers elevated. Okay, it just kind of helps confirm that this is an inflammatory process. You're going to see elevations in your cardiac enzyme because that inflammation is going to affect the function. It's going to add a stress to the myocardium. So you're going to see those troponins elevated in this. If you have enough of a disruption of the function of the heart, then your BNP might be elevated. So there's a couple of things that you might see on your lab, but nothing specific to myocarditis. So it can make it a very difficult disease or a difficult condition to diagnose. If you needed that definitive diagnosis, then what you need is to do a biopsy of the myocardium. They'll look under the microscope and they'll apply the Dallas criteria to it and see if it meets that criteria to be able to diagnose this with myocarditis. And the Dallas criteria is basically just, you have this inflammatory infiltrate in the myocardium that is not typical of what we would see as far as an inflammatory reaction if the myocardium was dead, like with a heart attack. Okay? So it's just as there's a different kind of inflammatory picture with myocarditis as opposed to a heart attack inflammatory process. How do you treat it? Well, it's going to depend on how they come to you. If they're dead, then there's probably not a whole lot you can do for it, right? But otherwise, if it is, they're coming in with like heart failure, well, let's manage those heart failure symptoms. If we know what's causing it, it's COVID-19, let's treat the COVID-19. So treat the cause of this and treat your clinical picture and kind of wait it out until the myocardium has had the opportunity to recover from that inflammatory process. So, questions for me? And we have done infective endocarditis, yes. So there is another mark that should be on that. So I'll fix that. But okay. So tomorrow I'll post when I get back to my computer, I'll post the review slides for this block onto Canvas. We'll meet and we will go over the review slides. Lab on Friday, it'll be myself, it'll be Dr. Klein, our pediatrician, teaching the congenital heart disease part to us, and then Major Kelly is going to help me with the inflammatory side of this. But we'll be broken up into 3 groups because I'll be teaching the heart sounds part to it. But we'll be broken into 3 groups, and then we'll rotate to the 3 stations. Probably anticipate about 2.5 hours for the total lab, about 45 minutes each station. And then I've been told it's a great review for my test. So hopefully you can get a lot of learning value with that to prep you for the test on Monday. I'll see you all tomorrow.